And Brian, it's a bummer on the whole IOLC. I was really looking forward to going to Europe this year, but I'll attend virtually and make sure that I do make it the following year.
That sounds
So
great.
as Brian said, we're going to, as Brian said, we're going to be talking about immunotherapy, and we're going to be talking some new advances in radiation therapy. I find them very interesting. I hope that you do as well. As we go through this, this is me, as you know, we're going to be talking mainly about the abscopal effect. And you may or may not have ever heard of the abscopal effect. We're going to go into that. We're going to go into what it means. It's actually been around since 1953, but only in the year 2000s and above have we really made some real progress with it. Immunotherapy, most of you are probably already familiar with immunotherapy, and with the chemotherapy regimens that we have nationwide, that's become sort of a mainstream. Not so much with radiation in the way that it's that we're talking about in some of the studies that are out there these days. We're going to be covering those quite a bit. So what is the basic objective that we're looking for? It's to preserve the immune system. So those of you who may be aware, when radiation comes in and it targets a particular tumor in the body, it does hit that tumor and destroy that tumor, but it also damages everything on the way to that tumor. And if you have to include nodes and everything else, well, then that's just that much more tissue that's being irradiated, which affects our immune system. And we'll get into a little more of that. So the goals are preserve the immune system, irradiate a smaller target, and look at immune system maintenance. So we want to maintain as much as the body's natural immunity as we can. We want to increase the effectiveness of the immunity system, and then we want to have a more targeted, smaller amount of radiation, targeted radiation, and then the abscopal effect happens. So what happens there is we're training the body to where if we build up the immune system and we are able to hit just a small targeted area, then the body learns and the body can then go get distant metastasis. So if we've got nodal involvement or metastatic disbursement throughout the body in other areas, we're teaching the body how to recognize that. It's pretty amazing, actually. So what we're looking at in addition to that is right now in some preliminary studies, they're also looking to include biomarkers, or they're also known as molecular markers, signature molecules, whichever you call them in your facility. So basically, a biomarker is looking to see how well the body responds to a treatment for a particular cancer diagnosis and where it's located in the body. The abscopal effect. Abscopal means the AB part is far away. Scopus is a target, so a far away target. And if we hit the tumor, but we have nodal involvement, which is far away, the abscopal effect without radiation treatment to those areas still reduces the cancer. And that's really what's the amazing thing. So as mentioned before, the abscopal effect was first described by Mole in 1953. So again, just as how radiation works. When radiation comes in, it damages all of the different cells that it's passing through. And our normal cells, when they get hit by radiation, we have components of our body known as repair, recovery, repopulation, reoxygenation. Those are the 4 R's of radiation. So normal healthy cells, when they're hit by radiation, are able to repair themselves. And that's why, just like when you get a cut, you have a scab, you have a scar, and then sooner or later you can't really tell that you had that cut. Well, the same thing happens inside our body with normal cells. Cancer cells, everybody on the planet has some type of abnormal cancer cell floating around in their body at some period of time. but our immune system goes through, recognizes these abnormalities, destroys them, and gets rid of them like any other waste in our body. What happens with a cancer cell is that these cells, for whatever reason, decide to latch on somewhere and continue to grow and grow and grow. So it's just basically a cell that in our body that didn't know how to do anything else except reproduce. It's sort of a messed up cell. Well, because it's abnormal, it can't go through all of the repair the way that our normal body does. So when that happens, that's why radiation works. So given that, we start looking at radiation delivery. So when you do this, radiation delivery actually stimulates the immune system. And preclinical trials are confirming that radiation therapy induces a tumor-specific immunity or immunogenic cell, and this is by Formenti. Recent advances in immunotherapy also allow for a theorized easier avenue to the abscopal effect. So what was done back in 1953, we didn't have the ability to add some of the new advances that we have now in immunotherapy. So what we're doing is there's 4 parameters that are being looked at. And in this, what we're looking at is we're going to combine immunotherapy to build up the immune system of the body. And that part, we're not quite sure of. So should we do it before we give the radiation, during the radiation, after the radiation? That part right now is still in clinical trials, but amazingly, some of the clinical trials are showing that whether it's before or during, after, they're still seeing an abscopal effect, which is fantastic. The thing about that is, what are the best doses? What are the diagnoses that work the best? You know, where in there, you know, if we have a 2% increase or a 10% increase of doing it simultaneously, all of that right now is being studied. So that's the radiation parameters, along with the sequencing. So, you know, how many days do we treat the patient? What dose do we give them? Those are the parameters. Should we give it during, before, after? And then we have to define what the abscopal effect means. So does the abscopal effect mean that we can just treat the primary tumor? And if we have local nodal disease that is very proximal or close, or do we have the ability to even say, here's the tumor, and we have and it's in the lung. We have very distant metastasis that might be in the knee. Are we seeing a result there? And that's defining how the abscopal effect in particular is. And then, of course, patient selection. So do we want to have curative patients? And do we want to target only curative patients of the breast or only curative patients of the lung? Or do we want to have bone mets? Do we want to have brain mets? Do we want to have prostate and bone mets? And all of that kind of stuff is what we're looking at. Or is it curative? Is it palliative? Is it what type of patient population in each of those? How do we recognize when the abscopal effect took place? So again, the core here is, and the amazing thing is that we can treat the tumor and not treat another lesion that's far away and still see reduction in both. When I say the abscopal effect, just as a reminder, that's what I'm talking about, is non-irradiated reduction of tumor. That's amazing. So time to recognize an abscopal effect was defined as from we gave our last treatment today, how long does it take to have a measured response from a non-irradiated site that reduces in size? So along with those studies, we're trying to see how many fractions of radiation therapy we're going to give. According to a paper titled Spontaneous Regression of Metastatic Renal Cell Carcinoma Following Palliative Irradiation of a Primary Tumor, and you can see the reference there. What we're talking about is, as with anything that's new, there's a lot of conflicting studies out there. So some of them are give one single fraction, 20 centigrade. Look at 24 centigrade in 3 fractions, so 8 centigrade per fraction 3 times. Or do we want to give 30 centigrade in 5 fractions? And right now it's too early to say what's the best route is, and we may end up with maybe they're all applicable, but they're all applicable to different diagnosis sites. So for example, perhaps the 20 centigrade is responsive in pediatric tumors. The 24/3 might be responsive in prostate, and the 30 might be responsive in breast over 5 fractions. Whatever the case is, that is all stuff we're studying now. In a phase 1 study, Maedy, he tested hypofractionation. So the 24 centigrade in 3 fractions versus the 17 centigrade in 1 fraction. Here's the thing, which in my opinion is really a good thing, because whether it was 1 fraction or 3 fractions, he still saw abscopal effect benefits. So even though you're just treating the tumor that was cancer far away, that was reducing in size without radiation. That's because immunotherapy had been given to boost the immune system. And if we start looking at another paper, it's very interesting. I would encourage all of you to do your own research and look at, there's too many clinical studies and too many papers to have in a single hour presentation, which is actually a very good thing in my opinion. But if we look at this, we've got the abscopal effect of radiotherapy in the immunotherapy era. So systemic review of reported cases, that's the title. Of the cases that were done, 23 out of 24. Near 100% response rate with abscopal effect when you add immunotherapy. So that's really amazing. And as I said, while they all received the abscopal effect benefits, the real question was, do we give it concurrently or do we give it immediately before or after? Those are the real questions. So if you've never heard of the abscopal effect, or you've only peripherally heard of the abscopal effect, that's the point of this presentation. And if you look, and it would be not unusual if you'd never heard of it, look at the studies that are happening, the clinical trials. If you look in the year 2000, there were just a few, and there were some studies back in the 1900s, but they were always single digits. I believe the most it had gotten to was in the 90s, where there was maybe 10. But keep in mind, back in the 90s, we didn't have access to the type of immunomodulation, immunotherapy that we have today. So the recent, if you start looking here from 2010 to 2018, and I wasn't able to find 2019, which would be last year. But if you look at this, these are the number of publications that are talking about the abscopal effect. So just since 2016, 17, and 18, look at the number of publications, especially in the 2 years before last year, 17 and 18. And I suspect that 2019, because I know a lot of researchers that are out there, I suspect that 2019 is going to come in even higher. Now, according to last month's most recent data by PTOG, the Particle Therapy Cooperative Group, there are 108 operating either proton or carbon ion facilities in the world. 108. 36 are under construction, and another 28 are in the planning stage. This is pretty extraordinary, actually. If you break it all down, you can see this is throughout the world. The United States now has the most. And I got to tell you, back in 2002, 2003, there were, first of all, there were only 2 proton facilities in the early 2000s, and they were at Mass General and Loma Linda in California. They were the only 2. They were hospital-based. Then the Indiana University donated a proton accelerator to Bloomington, Indiana, and that became the first freestanding proton facility in our country. I was lucky enough to be able to go in and manage that operation for the first year, get it off its feet, and then negotiate some pricing for the first freestanding facility of protons in the United States. It was quite an adventure. And it is a small little town to have protons. That would have been impossible with the huge expense of an accelerator had it not been donated by Indiana University. So that was near $100 million donation. It was incredible. If you look at this, we can see that the United States has 39. The next nearest country is Japan, and that will come back into play later in the presentation, because while we have now surpassed them, they actually have a lot more experience than us in this area, and a far more experience than the rest of the world in carbon, which we're going to get into as well. Once we started seeing what was going on with the rest of the world and some of their benefits, Germany and such, then we started ramping up and picking up our volumes. Along with that, you'll notice that England has really come up as well. And why that matters is they were referring a lot of their patients, a lot of the pediatric cases here to the United States at various proton facilities around the country, Florida, New England, California. And then those, because they were sending so many patients to the United States for proton treatment, they decided to invest in their own. These are world facilities that are under construction as of July of this year. And you can see that it's throughout the world. The United Emirates, Argentina, South Korea has actually got 2 underway. The United Kingdom has another 2 underway. Australia, China has 8. And the US has another 8. That's quite incredible, actually. So there's widespread utilization. We've got academic centers, we've got major cancer centers, we've got the national health systems that are in place, even private physicians in small areas or mid-sized towns in Louisiana, Oklahoma, throughout the country, mid-sized communities are doing private facilities. Of course, large management companies are getting into the play as well. Those are all for-profit. There are non-profit, there's non-profit facilities. But I guess the major message here is that at one time, the question was, are protons safe? Are they good in medicine? Is this a questionable, overpriced thing that we should get into? And in my opinion, the answer is no. The clinical studies are really going to show that, and they're very, very promising, especially seeing the combination with immunotherapy. In addition to that, every major medical institution that trains new physicians either already has protons, is exploring protons, or in the planning stages of construction for protons. So they are here to stay for our visible future. So the next question is this a disruptive technology or is it an additive tool? I suppose the answer is both. If you look at this, it's disrupting some of our options, but it is an additive tool. It doesn't take away, and this is not a replacement for conventional radiation therapy. It's an additive when an option that we can now use as another toolbox. We can treat patients now. It's adjunct because we can now have patients with immunotherapy, radiosensitizers and such. If we start looking at this, is that we don't always have one option. It doesn't always just have to be conventional radiation therapy. And that's where politics comes into play. And I'd rather not talk so much about politics. I'd rather talk about what are our patient outcomes. Because proton therapy is going to continue to grow. We're going to Here's what's going to end up happening. Those of you who were back around in 1995, you know that in that era, the late 90s, is when IMRT came into being. And those of you who go really back, you'll know that we didn't really have a code for IMRT to build. This is way back even before 77418, which has now been replaced with the simple and complex codes that we now know. Before 77418, there were G codes, temporary codes for IMRT. And at that point, I worked for a company, and we had some of the first utilization of G codes. And we were pushing them out to our nationwide network. It was a publicly traded firm. And at that point, what we started looking at is negotiating what we were going to get paid for those G codes. So we set the baseline reimbursement for IMRT, and those of you who know, that was fantastic. Well, back in the day, the story was IMRT is going to destroy Medicare, it's going to bankrupt the system, and all of this kind of stuff. And I've got some, I think, some interesting financials towards the end of this presentation that you'll see that that was never the case. That was never a concern, but that was what was put out there. That's what was sort of making the news in radiation therapy, and it's a shame. We, of course, overcame that. It's very hard to find a radiation facility in the United States that doesn't have IMRT or doesn't have that an option. And although it was only predicted to be 15% of patient populations under treatment, those of you who run cancer centers that have radiation therapy, you know in your own facilities, most likely you're at a minimum 40% of your patient population is IMRT, and likely up to 60 or more given your curative mix. Now, the same thing is going to happen to protons. Protons are going to be continued to proven better and better and better. They're becoming more and more affordable. We're starting to see that every metropolitan area with a major population of at least 300,000, 250 to 300,000 is going to have certainly access to at least one single vault in the next decade. So the cost benefit studies are going to continue to show greater value, and not only greater value in reducing the cost to come in, but one of the things that's going to be studied and is being studied, but we just don't have enough published data yet, is the long-term outcomes. And why don't we have a lot of long-term outcomes? Well, because we only started having a lot of proton facilities after 2007. So we're relatively new, and it takes 10 years to develop accepted outcome data. So now what we're doing is some of that data that was already good, we didn't have advanced targeting imaging systems like we do today with our IGRT. We certainly didn't have immunotherapy. So when you start looking at advances that the vendors have made in IGRT and how to image tumors, and then you start looking at combining immunotherapy and adding abscopal effect, immune system boosting, and destruction of distant tumors, these studies are just going to continue to get better over time. And it'll be exciting to look back on this presentation 10 years from now and see the advances that will have been made. So is this going to have, now, I should mention that while I'm focusing on protons, this does not mean that conventional radiation therapy, IMRT, SRS, SBRT, don't have the same abilities to do the abscopal effect, because they do. They absolutely do. And it's going to improve all of radiation therapy. Why I'm focused on protons is because when we start looking at APMs and when we start looking at reduction of reimbursement, I'd like us to consider the impacts that may not have been thought out of what that does to innovation in radiation therapy. Not just the innovation in radiation therapy, but, and most of you, I'm certain, have either experienced protons, have been to a proton facility, or are aware of them, and certainly have heard of them. What you may not have heard of is carbon ions, and we'll talk about that in a little bit. You may not have heard of neon or helium ions. And all of this is super exciting stuff. Basically, it's designer radiation therapy. We don't have all of the access to those treatments in the United States, even though carbon ions were invented in the United States because of their cost structure. And if we start reducing our reimbursement to the radiation world, we could, in my opinion, endanger some of the innovation that's coming forward. And that's sort of my push on value best practices and what's coming. This leads me into budget neutrality. And all of you, as cancer executives, are well aware that all of your physicians are specialists. Now, if we look at this, this is a busy slide, but if you look in here and you see here's radiation oncology at negative 28%. If we start looking, this graph shows a comparative analytics of Medicare payments for select specialties since 2006. So this is, I pulled this, and 2006 is really pulled in 2007. So if we've got 2007 to 2021, we're seeing that family practice and internists and all of those guys and gals that were in podiatry, psychiatry, family practice, internal medicine, I don't want the message to be that they didn't deserve to get more money, because they did. They were underpaid. And family practice, good for them, over this time period has gotten an increase, average increase in pay of 43%. That's incredible. Fantastic, good for them, well-deserved. Internal medicine, 24%. So don't have that as an issue. But the way budget neutrality works in the United States, in order for them to go up that much, other specialties had to go down. And let's look at the specialties that were most affected by the going down part. We can see that diagnostic testing facilities had a 64% decrease. 64% decrease. Radiology, 41% decrease. Interventional radiology, which most of us at some point in our oncology world, we're talking to those interventional radiologists because they've got to see where the tumor is, what's affecting all of those kind of different deals. Interventional radiology, 32% reduction. Radiation oncology is a 28% reduction during that time period. We start seeing this, in my opinion, it's fine. Budget neutrality works that way. We had to have a reduction in order for some other physicians to make more. I get it. But when does that pendulum shift end? When do we start saying enough of the budget neutrality? Let's not move in that direction any further. And if you look at, so our company wrote, I sit on several boards and are able to affect their transmissions to senators, congressmen. Those of you may have even gotten a recent letter from me saying to send out a letter to your senator and congressman, and I suggest that you act on that. And it's addressing that very thing, the very thing on budget neutrality. And according to the latest available data, which is 2018 from Medicare, it appears, and that was not inexpensive, by the way, it appears that 2,112,347 in the MPFS portion, because keep in mind, we're not talking about HOPS in this particular deal. HOPS does have its own issues, but we're talking about Medicare physician fee schedule, which just talks about physician reimbursement or freestandings. So 2,112,000 treatments occurred in the United States in 2018. And within that world of radiation therapy, we take out the CPT codes for protons, and they represented only 84,847, or 4% of the total MPFS treatments. When we get freestanding facilities, unlike regular radiation therapy facilities, there are carrier priced, meaning you still have to, when I started that first facility in Bloomington, Indiana in the early 2000s, we had to go to Medicare, discuss rates, educate what protons were, and get a reimbursement rate. Luckily, we got phenomenal reimbursement at the time. Amazingly, many years later, in 2021, we are still gonna have to go in there and negotiate. And why? Because they won't follow their own formula. They won't follow their own formula of what is the practice expense. We know the accelerators are extremely expensive. We also know that the vaults are extremely expensive, and they don't want to include the vault in any proton reimbursement, which makes it drastically under reimbursed. So in what we're doing is we're seeing these freestandings have much lower reimbursement than HOPS or hospital-based. So we're asking, even though the formula says we should be getting higher reimbursement, we're simply asking to be fairly treated for them and get 95% of hospital pricing. In addition, when you start looking at the failure to recognize the practice expense, just like we talked about, it doesn't take into account the pediatric, brain, head and neck, esophageal, advanced left breast, prostate, liver, CNS, reirradiated patients, and highly complex tumors in non-surgical locations that were previously sent to hospice to pass away are now accessible with protons and having symptom reduction, life increases, and quality of life improvements, which decrease the aftercare of radiation and improve the aftercare of radiation. So that reduces hospital visits, that reduces all kinds of side effects, that reduces additional hospital stays. That part hasn't been properly allocated, in my opinion, nor has that been taken into account in expense reduction. Now, when you start looking at protons accounted for $86,118,000 in 2018, all of radiation. If we took every freestanding facility in the United States, it added up in all treatments, every treatment, whether it's IMRT, SVRT, whether it's brachytherapy, HDR, LDR, it doesn't matter, all of them. I added them all in. We've got protons at 86 million, and we've got all of that radiation at $792 million. Now, $792 million is a lot of money, but it's all relative. When we start looking at the IQIVA, Institute of Human Data Science, 792 million, less than 1 billion is a lot of money. Cancer drug spending in 2017, this is 2018 data for radiation. Cancer drug spending alone in 2017, a year before, was $50 billion and predicted to reach over $100 billion this year. Over $100 billion this year. Every facility in the United States is freestanding. All of them were less than $1 billion in radiation oncology. And protons made up only 86 million. So all of 2018 radiation therapy delivery, which is, if we look at MPFS, how much of the total radiation population is that? MPFS is about 33% of cancer treatment. 67% of radiation therapy is delivered in hospital settings. But this accounted for 1.59% of cancer drug expenditures for 2017. So all of MPFS accounted for 1.59% of cancer drug expenditures. 2018 protons extracted from that, so 0.17%. So far less than 1%. 0.17% of 2017 cancer drug spendings is what protons are. So, and again, all we're looking at is the oncology world. We're not even taking into account the whole rest of medicine. but just as a comparison, 0.17%. Why does this matter? Because we have research to do. The abscopal effect is coming. What we start looking at what we're going to do with our outcomes with our cancer patients and how we're going to be able to combine chemotherapy, immunotherapy, radiosensitizers, all of this kind of stuff is going to have a huge effect. As of 2019, 22,000 people received carbon ion treatment. This is last year. 22,000 people received carbon ion treatment. There were 13 facilities that are active in the world. Only 13 in the world. Germany, Austria, Italy, Japan, and China. We created it. We created it here in the United States and California. And but it went away. Why did it go away? Why did these other countries take it into account? Well, it was costing anywhere at that time when it was going on, it was $500 million to build a carbon ion facility. Government research wasn't willing to fund that. They had brought it down to about, so believe it or not, $300 million expenditure is actually a huge savings from $500 million, but that number is still very high, and in some estimates, it's still around the 200 million mark. So, however, all that said, carbon ions are already contracted in the United States, and there are 2 facilities under contract, under construction, and planning stages that are coming back to the United States. Why does that matter? Well, we're able to, when this comes on board, we build radiosensitizers, immunotherapy, and because of the abscopal effect, we're able to do lung treatments in a single fraction, 1 fraction. It's amazing. So if you start looking at this graph here, you can see that the cancer and the blue line is protons, which the green line is photons, which you can see that there's going into the body. There's a large deposit of radiation that occurs. Protons and carbon ion similarly reduce the amount of exposure to normal tissue in the body, and protons deliver quite a good punch to the cancer itself, and then immediately falls off after it treats the cancer. That's the fantastic thing about protons. Carbon ions is even a magnitude greater than protons, so it would be exciting. Some new things that are coming in 2021, we're going to see a deletion of our new patient visit of 99201, and we're going to start seeing our 202, 3, 4, and 5 move to time-based. And if you start looking at this slide here, it's showing us our comparisons of 2021 compared to, so next year compared to last year. We're going to see that the typical time for the 202 and 3, 4, and 5 in 2019 for, let's take 204, which is the most common new patient, was 40 minutes. In 2021, it's 45 to 59 minutes. The most common follow-up in 2019, last year, was 15 minutes, and in 2021, next year, it's going to be 20 to 29 minutes. So both the times have increased, but we still have an easier way of reporting them based on time. We're still going to, in hospital settings, we're still going to bill our E&M facility visits, physician visits, whether they're new or established, with the code G0463 that is set to stay in place. We've got to have adequate documentation. So here's the thing about the ROAPM. Although we're going to be billing less, our documentation isn't going away, and we still have to document every service we did, even though we're going to report a start code and a finish code. A lot of folks are thinking, well, that doesn't really matter about documentation in the middle. That's actually not true. You have to still document everything, and you have to have parallel reporting, meaning you have to capture all of your codes that you would have, like you did in the past, and then you have to submit your new test code and your new finish code in addition. Industry is not ready for this, in my opinion, where there's no way we're going to begin in January 1st. Some folks believe that we will. I just have a hard time believing that because we don't even have the financial specifics that aren't due to be released until mid to late November, and industry putting that in place in 30 days and physicians learning how to do everything appropriate in 30 days. I just don't believe that's going to be possible. We've written many letters to Washington, D.C. You may have been on listserv that I've asked you to help contribute with those letters. It's not that we want to do away with APM, we just need more time to get it right. So basically, CMS does all of your documentation has to be in place. This is correct documentation. When someone walks into your facility, they should be able to open up from time of consultation to completion follow-up, look at everything that happened on that patient, how many times it happened, what the diagnosis was, what the treatment was, why it was that way, any special physics consults, any special requests, weight, blood draws, anything, and not ask a single person a single question. That means you have perfect documentation. Data services matter. We recommend that you're going to bill on the date of the plan, not the date of physician approval. Either is okay, but stay consistent with that and don't change it around. As you know, we have some telehealth approved codes because of COVID. We know that 77427 can be done telehealth. And in that instance of telehealth, what they're really talking about, even though it could have been distanced in the past, what they're really talking about is that the patient who either has COVID or has symptoms of COVID, and we don't want the doctor exposed because then that doctor is going to be talking to a lot of other patients. So if they're in their office and the patient's in an examination room and they're doing telehealth that way and they're not physically there with the patient, is that okay? Yes. If they are at a distance or not at that facility for this time period, is that okay? The answer is yes, because of COVID. It's my recommendation that over time, that needs to go away, and we do need to have patient visits physically with the radiation oncologist once there is a vaccine and there is no more cause for concern to expose a vulnerable population. So it's my position that 427 really should be patient physician face-to-face contact, because if not, we're at massive risk for a rate reduction for that code. That said, I believe the reverse is true for our new patients, our established patients, our inpatient hospital care. In my opinion, which could be wrong, but that would be extremely rare if I were wrong, is that if we start seeing patients, and for those of you in particular, whether it's chemotherapy, whether it's radiation therapy, whether it's protons, all of those, you know that sometimes it's difficult for an elderly person if they don't have family members, or they don't have a ride, or they travel to you from a different state or even a different country. If you're able to do a follow-up and basically check on them, and that was going to be a 5 or 10 minute visit anyway, and you're able to do it maybe 15 minutes, if you were able to do that telehealth, you saved the patient, you've made yourself far more efficient, you now have better follow-up for your studies on trending patients and reporting to the state. You now have the ability to see those, and it's our push that all 99 codes be permanent telehealth and not go away and still be reimbursed at the same level. That is our position with the 99 codes. I just disagree with the 77427 for the reasons I mentioned. Keep in mind that oncology right now is under review, specifically by the Department of Justice and the Office of Inspector General, unfortunately, because of blatant fraud, intentional abuse, to try and extend patient treatments or give patient treatments that in their mind wasn't necessary. Unintentional abuse, sloppiness, ignorance of the rules. In particular, IMRT, supervision, signature fraud. So supervision is still in effect for MPFS, and if your hospital has a more stringent supervision rule than the final rule, they actually hold you accountable to your hospital and not the government's rule. Signature fraud, treatment fraud, and unit fraud. So what happens in a DOJ review? If some of these things are reported or under investigation, they'll do an analytics request. They'll see how is your doctor reporting compared to the rest of the doctors in the same tax ID? And then how is that doctor or that group reporting to the other same specialty in that city, and then within that state, and then within the country? And you begin to paint yourself as a statistical outlier. That's why it's extremely important for you to not just say, all my new patients are level 4 and all my follow-ups are level 3, even though I document a 4, even though I document a 5 or whatever, even though I'm saving the government money, just to make it easy, I'm just going to bill everybody a level 3 follow-up. That may be a good intention. That's something not to do, because it will encourage you to be a statistical outlier to your peers. And even though you may be okay in that follow-up, what you don't want to do is draw attention to all of the codes, whether it's chemotherapy, radiation, surgical, it doesn't matter. It'll start looking and see the rest of your reported codes. So after the analytics request, they do a sample review, maybe 25 patients. If you have 25 patients that are recommended for review from the Department of Justice, don't panic. Your lottery number could just be up, it could just be random. After that though, they want to confirm the issue. So if you get another 25, you're being profiled. Don't change your medical records. Keep them as they are. Then they'll look at validations, they'll look at estimates of overpayment or categorizations of potential issues. If you recognize that there truly was an issue that you were unaware of at the time, self-report it, give whatever was not due back. You'll save vast amounts of time, huge amounts of headaches, and a giant amount of revenue. So here's what's going on with the G codes. They're supposed to go away January of this coming year. We'll see. Yeah, they were supposed to go away since for many years, and the latest was last year and this year, but as we know, that did not happen. We're looking at supposedly a mandatory implementation of the RO-APM January of this coming year. Even though we were supposed to have it January this year, it didn't happen. They're now saying it for 30% of the population, it is definitely going to happen in 2021. That should say 2021, not 2020. It's my belief that's not going to happen, and that we're going to have either summer of 2021, or I'm taking bets that more likely it's going to be definitely either summer or even next year, 2022. And so is the new RO-APM less work? Well, not in the beginning, no. It's going to be more work, because you're going to still have to document everything. You're still going to have to capture all your codes, but now you're going to have a different parallel reporting mechanism to see if that works, which would be monitored over 2 years. So there's going to be holdbacks, and that first holdback is going to be looked at a year after the occurrence occurred to see if there was any adjustments that needed to be placed, meaning they paid you a certain amount, they can take some money back, or they can give you some additional money. And then at 2 years after the patient is done, they can again take some money back or give you some money to you. I am not real excited about this. And if you start looking at the OCM, the oncology care model, and start looking at some of the findings that they had, there was no material decrease in expenses. There was no material increase in revenues. It was virtually flat. There was not a lot of change for a lot of headache and a lot of stuff. Now, individual practices, of course, went up and down, but as a nation, there was not impressive results, in my opinion. So I believe the same thing is going to happen with this RO-APM. We really got to keep our appeals in place and our documentation, especially with oncology, whether it's medical or radiation. It costs, according to Change Healthcare, it's about 9% of claims are denied, and they do a large volume of claims. It's about $118 per claim to work. So roughly 1 out of 10 claims is denied. If you do quick math, and a low volume medical oncology department or radiation oncology department does about 2,000 claims per month. That's a low volume. That's about 180 claims, which is about roughly $21,000 or $254,000 a year just to work appeals, just to work appeals. If you're high volume, that number can easily get into $1 million, $2 million of actual costs. That doesn't include your equipment. That doesn't include your building to house stuff. That doesn't include your practice management system, the supplies, all that kind of stuff. So it can be costly. Given that it's costly, we want to avoid one of the top three issues with denials and payment, which is authorizations, lack of authorization. We want to make sure the type modality, not just radiation therapy, whether it's IMRT, HDR, exact drugs, therapeutics, immunotherapies. We want to ask the payer to pull recordings. If you know you told them something, we want to verify the date span and CPT codes. UHC often requests medical records, even though you've done an authorization. Blue Cross Blue Shield, because of COVID, is now accepting more faxed records. Many payer calls are being sent overseas. Don't allow that to happen. Ask for someone in the US. Never take, they'll call you back in 24 to 48 hours is acceptable because it won't happen. Letters of agreement are often not followed. So if they tell you they're going to pay you $10,000, many times what they'll do is they may pay you $5,000 or $8,500. So you want to go back and get that other $1,500. You want to always double check your interfaces and upgrades, because your interfaces between your whatever's capturing your, whether it's links, whether it is ARIA, Mosaic, whether it's Cerner, Epic, you want to make sure all of that kind of stuff is talking to each other, and every quarter test it. What we're seeing is sometimes the authorization component will go off. So immunotherapy and immunomodulation. Immunotherapy is a treatment that uses certain parts of our body's immune system to fight disease such as cancer. This can be done a couple ways. It's stimulating or boosting the natural defenses of your immune system so it works harder and smarter to find and attack cancer cells. It's making substances in the lab that are just like the immune system components and using them to restore and attack and find cancer cells, which is the whole concept of abscopal effect. If you're using immunotherapy, we want to use this, and you're just doing that alone, or you're using the radiosensitizers. Radiosensitizers alone would be the Z5111, and then the rest of the stuff. And your primary code for immunotherapy alone on that day would be Z51.2. So immunotherapy, they include monoclonal antibodies, checkpoint inhibitors, cancer vaccines, and non-specific immunotherapies. Here's a list of some comparisons. All of you on this call probably know your traditional chemotherapies. Are you familiar with all of the immunotherapies? The Avastin, the Erbitux, the Yervoy, Opdivo, Rituxan, Herceptin, all of you in medical oncology, I'm sure are, but are you in radiation therapy? And how does immunotherapy work? Basically, a blood sample comes in, immune cells are isolated, then those cells are enhanced. So for example, in CAR T cell cancer therapy, isolated T cells are engineered to express CARs that recognize cancer cells. Then the doctors give this enhanced immune cells back into the body, and then they seek out the cancers. Yeah, amazing. So when you treat with radiation, what this slide is telling you, you can just hit the radiation, the main tumor, and not have to worry about metastatic disease that is distant, because this, in theory, which is being studied right now, is going to be able to allow us to not treat nodal involvement or distant metastasis because the abscopal effect will train the body to go find them. Amazing. As we talked before, SBRT is certainly applicable and applicable with protons. Things you don't want to do is, if you don't think a patient's going to benefit, obviously don't use SBRT. You don't want to have widespread cranial, and you don't want to have poor performance status. So if somebody's in a bed and unable to be mobile, that they probably are certainly not the right candidate for stereotactic. Now, How do you bill for a stereotactic? You're going to have your clinical treatment plan, simulation, your 3D plan, or your IMRT plan. If it's IMPT, you're going to have your calculations. If you made a custom immobilization, it's 334 per arc, or IMLC, you're going to have your 338. Your radiosurgery management is 432, and then what level treatment delivery and how many times did you give that treatment delivery for protons, or whether it's IMRT or any other radiation. Then we're going to have our continuing physics and special physics, and you can see there that we included your neurosurgeons should you have them participate on brain lesions. The proton delivery codes are there from 520 to 525, simple, intermediate, and complex. I would encourage you to have a Visio like this. This is busy, and you can certainly print this out and use it as a reference point, but not just for proton dosimetry. You want to have IMRT dosimetry, you want to have SBRT, SRS, you want to have it then further delineated to breast, prostate, lung, bone mets, etc. And it tells everybody in the department, the doctor, the dosimetrist, the therapist, the whomever, physicist, what is their part in the documentation? What is their codes that they're responsible for capturing, number of units, and is it professional or technical? If we're doing proton IMPT therapy, the codes are going to be E&M, the planning, for IMRT, the clinical plan for the physician, respiratory motion management, calculations, treatment devices, the weekly management, the treatments themselves, continuing physics, the special physics consultation when it's not for QA, and special treatment procedure when applicable. So basically, the message is our world is amazing. The radiosensitizers, what their job is to make the cancer weaker, less able to withstand the damages of radiation because there already are, but some tumors are not radiosensitive. And so what this does is it weakens those particular cancers and makes them sensitive to the radiation. Then you have immunotherapy on top of that, which boosts the immune system. And then if we're able to reduce our tumor size, which again, it boosts the immune system, it allows the body to better fight it, and fantastic survival outcomes. I'm extremely excited to see what happens certainly in the next 3 years, because that's when some of our data will be mature at 5 years, and we can start publishing a lot of this stuff that is related to outcomes, not just the clinical research that is occurring that shows promising, but we'll have actuals. And I'm very excited to see what happens in 8 years when we have our 10 years out there. So share your influence. Let's make this work as a team. Thank you so much for your time. I hope you found this interesting. I certainly do. I'm very excited about it, and I think it has a lot to show what's coming for oncology. Please keep in mind that when we talk about the expense of protons and carbon ions, which are expensive, they are. And if we start looking at $200 million for a single facility, and we start looking at cost reimbursement for protons and carbon ions, and it adds up to quite a bit for a patient course, that's all true. But let's also keep in mind the tiny fraction that all of radiation makes compared to cancer drugs, and then the tinier fraction that protons and carbon ions have on their footprint. In my opinion, I think it's well worth it. Thanks a lot. Happy to take any questions.
Thank you so much, Ron, for your time and your expertise. As Ron just mentioned, we'll open it up now for questions. You know, we're at the top of the hour. Anyone have anything before we end the webinar?
If one of the questions is, does it feel strange to talk to a computer instead of an audience? Sometimes.
Hopefully we're back in a ballroom very soon.
Absolutely.
Okay, so no questions coming in, but you do have Ron's email address on the last slide if you'd like to reach out and ask him any questions. As I noted on the top of the webinar, we will have this presentation posted on the ACE members only section and the ACE YouTube channel. So with that, I will close the webinar. Ron, thanks again for your time, and everyone enjoy the rest of your day.
Take care, everyone.
Yeah, take care.